Rivaroxaban for thromboprophylaxis in high-risk ambulatory patients with cancer. Definition: venous thromboembolism is a frequent complication of cancer and cancer treatment, with serious consequences for patients. Rivaroxaban therapy resulted in a significantly lower rate of venous thromboembolism. The incidence of major bleeding was low.
Blood clots are responsible for a number of serious and often fatal conditions. These include venous thromboembolism, stroke resulting from atrial fibrillation, and heart attack. In venous thromboembolism, a blood clot forms in a vein, usually deep inside the leg. The clot can cause swelling and pain. This condition is called deep vein thrombosis. If part of the clot breaks away, it can travel through the blood vessels, up to the heart, and from the heart, out into the lungs. Once in the lungs, the detached piece of clot can block one of the pulmonary blood vessels. When this happens, no blood can reach the area of the lung beyond the blockage, and so no oxygen will be collected from this region. This is called a pulmonary embolism, a serious and potentially life-threatening. Venous thromboembolism kills twice as many people every year in Europe as breast cancer, prostate cancer, AIDS, and traffic accidents combined.
Pros and cons. Pros. Rivaroxaban is used to treat deep vein thrombosis and pulmonary embolism. It works by decreasing the ability of blood to clot. It is also used to prevent strokes or serious blood clots in people who have atrial fibrillation. Is administered in a daily dose, lower rate of bleeding.
Oral anticoagulation with vitamin K antagonists has well-known limitations and requires routine clinical monitoring of coagulation parameters. The new oral anticoagulants represent novel direct-acting inhibitors of the coagulation factors 2A thrombin or XA. The compound with the currently widest clinical approval for oral anticoagulation in the group of the XA inhibitors is the direct oral factor XA inhibitor Rivaroxaban. Rivaroxaban was the first direct factor XA inhibitor with clinical approval for long-term oral anticoagulation in patients with non-valvular atrial fibrillation, and has since gained additional approval for the treatment and prevention of deep vein thrombosis and pulmonary embolism. Furthermore, low-dose rivaroxaban, in addition to standard antiplatelet therapy, has been shown to reduce cardiovascular mortality in patients following a recent acute coronary syndrome, and recently gained approval for the prevention of atherothrombotic events after acute coronary syndrome by the European Medicines Agency. This review article discusses the clinical use and benefits of rivaroxaban for multiple indications. If you like
Cons. Slightly higher risk of gastrointestinal bleeding than warfarin, bleeding from the gums, intense menstrual bleeding, weakness, fatigue, headache. Applications in medicine. Patients with cancer had elevated risk for venous thromboembolism could benefit from thromboprophylaxis.
The oral factor Xa inhibitors are a recent hot item. Dabigatran has just been approved for stroke prevention in patients with atrial fibrillation, and now in the New England Journal of Medicine, there is news that Rivaroxaban is useful for symptomatic venous thromboembolism. The report was actually about two studies done in parallel. In the first, Rivaroxaban was compared to subcutaneous enoxaparin, followed by warfarin or dicumarol. In the second, Rivaroxaban or a placebo was continued after 6 to 12 months of treatment were over. The outcome being recurrent embolic events for both studies. In the head-to-head comparison with anticoagulation with warfarin, Rivaroxaban was non-inferior with respect to the primary outcome, but Rivaroxaban in the second study was also superior to placebo. Remember that Rivaroxaban is a once-daily pill that does not require monitoring. Now it's been shown to offer a simple approach to short-term treatment of venous thromboembolism and a superior continued treatment strategy rather than simply stopping anticoagulation. I'm Peter Block with a CardioSource Heart Minute.
Issue applied in Ecuador. Remember that 1 in 5 patients with venous thromboembolic disease has cancer, and 1 in 10 to 20 patients with cancer will develop a venous thromboembolism.
Cancer-associated thrombosis there's a few different options. There's Coumadin, which has been around forever, but there's problems with Coumadin. Maintaining the INR is an issue, and then patients need to be on different types of chemotherapy drugs, and that can interfere with the levels of INR. So it's really important that we find better anticoagulants to use. And one approach has been to use low molecular weight heparins, which was initially used just in the hospital, but in cancer patients they're used in the outpatient setting as well. And more recently, novel oral anticoagulants or direct oral anticoagulants have come on board, and they're much more patient-friendly. They don't require monitoring. They're 1 pill a day or 1 pill twice a day, depending on the type of anticoagulant. So they're much easier to manage. Currently, ASCO and other guidelines recommend low molecular weight heparins as the standard of care. And what we wanted to do was sort of try and figure out what's happening in the real world and what are patients and physicians actually doing. What we found was that the standard of care low molecular weight heparins only used about a quarter of the time. Warfarin, the oldest anticoagulant in the setting, continues to be used about half the time, and then the newer anticoagulant Rivaroxaban has been used about a quarter of the time as well. So a lot different is happening in the real world. I think partly it might be driven by cost. Costs for for injectable drugs can be high, and direct-to-patient costs can be high, and that's one possible reason. It is a daily self-injection, and it's challenging to use, so patients may choose not to use it, and there may be other factors at play that we don't completely understand. We want to deliver appropriate therapy, but we want to be mindful of patient preference and cost as well. So sort of assessing risk and finding making sure the high-risk patients get the more intensive anticoagulation strategies, and the low-risk patients are managed, more appropriately in a patient manner is the best way to go.
ASH 2015 coverage here at Orlando, Florida. Thomas Baldrick joined now by Dr. Simon Mantha from Memorial Sloan Kettering in New York. Thanks for taking a couple moments out of your conference for us.
Thank you.
So you got a study on safe and effective use of Rivaroxaban for patients with cancer VTE. Let's talk about the risks first of treating these patients.
So the current gold standard of treatment for this condition would be an injectable, a type of low molecular weight heparin. And it's actually far from being perfect. There's a rate of recurrent VTE of about 9% at 6 months with this treatment, and a substantial risk of bleeding as well.
So you make use of Rivaroxaban. Tell us what you did with this study and why you chose to do it.
So we performed a quality assessment study. We accrued patients to whom we offered Rivaroxaban versus Lovenox or enoxaparin, and we accrued that in over a year's time, or a little more, 2014 until November of this year. And our plan was to have 200 patients in a cohort, which we achieved. And as of mid-November, we had 6 months of observation on all 200 patients in the cohort, hence the analysis, which is going to be presented Monday next week.
What did you find in terms of rates of major bleeding?
So the rates of major bleeding at the 6-month endpoint were only 1.6%, while the risk of recurrent VT was 4.4%, which is much lower than what was found in the landmark studies CLOT and DeltaCan. However, you cannot really compare directly a randomized study that happened 10 years ago or even more recently to such a retrospective study, but still it gives you an idea of the ranges.
What else was significant to you?
So those are the two most important endpoints, recurrent VTE and major bleeding. Also, there's an endpoint called clinically relevant non-major bleeding, which is a milder form of bleeding. And it also was about 4% in terms of risk at 6 months, which is very good. As far as the risk of death, there were no deaths related to bleeding or thrombosis as far as we could tell in our cohort, which is very important, obviously.
So where do you go next with this research?
So ideally, if we had the funds, we'd like to do, or anybody I'm sure would like to do a large randomized study comparing one of the low-molecular heparins to Rivaroxaban. However, there's reasons why this might never get done. So I think the next best thing would be to do other larger cohort studies like this, possibly more perspective with prospective assessment of the outcomes, because what we did a retrospective assessment of the events, which opens the risk of observation bias, of information bias. So ideally, if you want to do better, short of a full randomized study, you would do a prospective study where you would observe the patient and accrue events prospectively.
Well, keep us posted, Dr. Mantha. We appreciate it.
Thank you.
Thank you, sir.
Conclusion. In my personal point of view, primary thromboprophylaxis with Rivaroxaban significantly reduced the incidence of symptomatic venous thromboembolism in outpatients with cancer treated with chemotherapy. Further studies are needed to assess the effects of this prophylaxis on mortality and the cost of care for patients with cancer.